Hi everyone, welcome to ResearchMD.com. We have a great presentation today. Again, my name is Pramil Cheriyath. I'm a Program Director, Internal Medicine Residency, Transitional Medicine Residency, Director of Research, Assistant Professor of Medicine, two large medical schools. We've been doing a series of lectures on endocrinology. We started with the posterior pituitary and we finished oxytocin and then we talked about ADH. Today our topic is SIADH, Syndrome of Inappropriate ADH Secretion. Okay, so first of all, we start with our definition. Always the definition, right? What's the definition? It's a disorder of sodium-water imbalance, okay? What is the next thing over here? Characterized by hypotonic hyponatremia. Of course, you have to have hyponatremia. That's why hyponatremia, sodium is like less than 135. Has to be hypotonic. What does that mean? You got serum osmolarity less than 275, okay? So what else do you have? Impaired urinary dilution with the absence of, there is impaired urinary dilution. When you look at that, what happened to the urine osmolarity? That's greater than 100, right? So those are the three things. And in the absence of renal disease or any identifiable non-osmotic stimulus known to release ADH, that's why we making sure normal thyroid and adrenal function, normal, we have to make sure no recent diuretic use also. Okay, so just go over the definition again. Disorder of sodium-water imbalance, hypotonic hyponatremia, and you got impaired urinary dilution, and then you have to rule out the other identified causes which stimulate the release of ADH. Okay, now the next thing is let's look at the epidemiology. Okay, most common cause of hyponatremia in the world, my friends. Okay, so when everything is most common, if you are writing an examination, definitely they're always going to ask the most common cause, right? So in this case, the most common cause of SIADH, most common cause of hyponatremia is SIADH, bottom line. There's nothing other than that. So it's always kind of very, very important. Now, when it comes to the hospitalized patient, it also gets worse. Almost like 15 to 30%. Let's say 30% of the people in the hospital have hyponatremia due to SIADH. Okay, everybody got that. Now, if you look at the people with the subarachnoid hemorrhage, 90% of them have pneumonia, 80%. So again, the thing we need to know, number one cause of hyponatremia in the world, right? And 30% of the people in the hospital can have SIADH. So let's look at the causes of SIADH, right? Increased hypothalamic production of ADH. Let's look at the causes under that. Okay, first one, anything kind of neuropsychiatric causes, and then you have to think about infection, right? You have meningitis, right? We got encephalitis, you got abscess, like brain abscess. And when you look at the vascular causes, you just have to look at SDH, subdural hemorrhage, right? We already said the 90% of the people in the hospital come with the subarachnoid hemorrhage or subdural hemorrhage have SIADH. So vascular causes you have to think about subdural hemorrhage, subarachnoid hemorrhage, and the thrombosis. Now, when you look at the cerebral malignancies, you have to think about it, and other cerebral diseases which affect the brain, which is like HIV, Guillain-Barré syndrome, porphyria. Anytime you have a posterior pituitary surgery, you can have that also, okay, and MS and psychosis. Now, let's look at the drugs involved. Okay, it's very important. Drugs, let's look at the chemotherapy drugs. Cyclophosphamide, probably the most common, and then vincristine and vinblastine, the chemotherapy drugs is also very, very important, okay? And then you got SSRI, TCA, you got antipsychotics, MDMA, and bromocriptine. Now, the most important thing you need to know is very, very important is the recreational drug use, okay? When you have patient ecstasy, which is 3,4 MDMA, you can have SIADH. Very common, so I'm going to circle this. Very, very important is an examination question. Okay? Don't forget it. If I'm writing a question, they're always going to write about ecstasy or 3,4-MD. MDMA can cause SIADH. Okay? And then we look at the ectopic production of ADH, right? What are the causes of ectopic production of ADH? You got main thing you have to know about the small cell cancer of the lung. Another examination question, okay? Bronchogenic carcinoma, mesothelioma. If I have to write a question, I always write about the small cell cancer of the lung. That's the most important thing I'm going to write, okay? It can also cause cancer of the urine and pancreas, thymus, neuroblastoma, lymphoma, leukemia, Ewing sarcoma, and all of those things can also can cause it, okay? Now, when we talk about the potentiation of the ADH, you got chlorpropamide, tolbutamide, carbamazepine, cyclophosphamide, all can potentiation of the ADH. So it's very important to all three causes to remember that, okay? It's a long list, but make sure like you know about ecstasy causing, make sure you know about the small cell cancer of the lung causing like hyponatremia. Now, next thing we're going to do is look at the physiology. How does the ADH work, right? We talk about what are the three receptors, V1, V2, V3, but the most important is the V2 receptor or aqua and the aquaporin channels, right? Okay, now let's look at it right here. What happened to the ADH produced, right? From the hypothalamus, go to the posterior pituitary, they come to the V2 receptor, okay? And where are these located? Somebody tell me. Collecting duct, the principal cells of the collecting duct, okay? And then V2 receptor, there's G protein coupled receptor, which is actually GS, okay? Remember, V2 is GS receptor, V1 and V2 is like GQ receptor. Remember that, okay? And then activate the use of adenyl cyclase, ATP is converted to CMP, then you have protein kinase A, and then aquaporin channel 2, aquaporin 2, okay? That acts on the aquaporin, which is actually kind of located in the cytoplasm. It moved to the luminal membrane, and then you have this aquaporin channel kind of open up. What happens when you open up? You got this water, all the water get reabsorbed through right here, boom, boom, and it come to the blood, right? So what happened to our blood volume goes up. So this is a normal thing. So when you have like a dehydration or volume loss, this is osmoreceptors in the hypothalamus pick it up and you release ADH, actone V2 receptor, G-coupled receptor, and then aquaporin and water get reabsorbed. Okay, normal mechanics. Let's look at the pathophysiology. What happened in the pathophysiology when you have SIADH? Very, very important, right? Increase ADH release. Inappropriate release of ADH, right? So what happened to our plasma osmolarity? Because you got increased volume coming into the blood, your plasma osmolarity goes down, right? And then what happened to the urine? Because urine is getting, more urine and there's less urine, right? So what happened to the urine osmolarity? It will go up, okay? That's like the common, I think everybody know that. Right? You got decreased plasma osmolarity, increased urine osmolarity, that's common. Let's look at the other thing. You can have urine sodium greater than 20 milli equivalent per liter in the urine. That's going to be lost in the urine. That's very important. So what happened is like there's water retention, there's going to be decreased serum osmolarity, right? Which we talked about with the transient volume expansion. That will cause increased ANP, increased BNP, and that decrease aldosterone, and then your urine sodium is going to be lost in the urine. That will increase the urine sodium. That's one of the diagnostic criteria. Remember that, okay? And then the other thing also, this is like when you talk about SIADH, the volume status is always going to remain normal. This is the most common. If you look at the most common cause of euvolemic hyponatremia, I think I might have told you, like when you talk about in the world, the most common cause of euvolemic hyponatremia is ADH. Okay, so I wanted to make that. I didn't mention that earlier. So the most important finding in this then is the euvolemia, because the body is trying to. And how does the body keep euvolemic? That's what we need to know. Of course, decreased serum osmolarity is here, right? And then what happened? You get transient volume expansion. This production of increased ANP, increased BNP, that causes also like decreased aldosterone, right? So increase urinary excretion, increase urinary sodium excretion, and what happened when the sodium leaves? Water follows. Okay, so that's what happens. So euvolemia, the homeostasis created. There's always going to be euvolemia. They're very, very important findings. Again, SID is the most common cause of euvolemic hyponatremia in the world. Okay, now let's look at our definition, our diagnostic criteria first. Okay, first one is hyponatremia, which everybody know. Hyponatremia, you can say less than 135 or less than 130, you can say. Next thing is the serum osmolarity, right? It's like less than 275. The body always trying to keep the osmolarity like very, very close range. Urine osmolarity greater than 100 millimole per kg, and the urine sodium loss greater than 20 milli equivalent per liter. And there's a couple of criteria. You have to make sure the body, again, we talk about euvolemia. How do you make sure? Always look for the clinical signs of like euvolemia, right? Hypovolemia, what are the signs like if there's dehydration, like skin turge or tachycardia, those kind of things, clinical signs. So make sure, and then also you need to make sure there's no recent diuretic use, and you also need to make sure normal thyroid and adrenal function, because, no identifiable non-osmotic stimulus known to release ADH, okay? So everybody got that? This is the diagnostic criteria. Now, treatment, we're just going to kind of talk about like how to treat hyponatremia. That's the main thing. Most of this patient, you will see like asymptomatic, okay? How do you, if you treat this patient, you can do like a fluid restriction. That is the most important thing in this patient with SIADH. Now let's look at it. If you take the urine sodium and you add the urine potassium, divide by plasma sodium, and if it is greater than 1, you make the fluid restriction like less than 500 ml per day. Okay, and then let's look at if you look at the urine sodium or urine potassium, divide plasma sodium, come back 1, you restrict only 500 to 700. If it is less than 1, you have to restrict greater than 1 liter per day. Remember that. Like, it's very good to know, like when a patient comes in, you say, just don't write in fluid restriction. Let's say how many mLs you want to be restricted, right? When you talk about moderate symptoms, what are the moderate symptoms? Patient may be like fatigue, weakness, headache, those kind of things. Then you can say like, you can give IV fluid with, you add like always kind of good to add some Lasix. Like what happened that when you add Lasix, you can increase the water loss more than the sodium loss, okay? That's the reason we're adding the Lasix. You can make sure you correct all those. So maybe like 8 to 10 milli equivalent for 24 hours. If you correct too much, then you can have brain edema, osmotic demyelination syndrome, all that happens. Very, very important to correct only 8 to 10. And then you can use the vasopressin antagonist, which one is like they block the V2 receptor, which is conivaptan or tolivaptan, and all of those things you can use, okay? Now, let's say if you have severe symptoms. What are the severe symptoms? Patient come with the altered mental status. Sodium is like less than 120. Patient started having seizure. This is an emergency. You need to give 3% hypertonic saline, okay? When you give that, you can go up, you have to give correction is like faster. You want to correct it fast, right? You do like correction by 2 mmol per liter per hour correction. Fast correction is needed. We're going to come back and talk about like, how to treat hyponatremia in another presentation. So let's summarize it again. Like, it's very, very important. I'm going to stand back. Let's look at a whiteboard. What's going on? Everybody know the definition. Hypotonic hyponatremia, increased urinary dilution. Again, most common cause of euvolemic hyponatremia in the world. Okay, most in 15 to 30% of the people in the hospital can have 90% with the subarachnoid hemorrhage and subdural hemorrhage, and around 80% of the people with pneumonia can have hyponatremia also, right? And you got this huge list up here. That's the neuropsychiatric cause, infection, vascular, cerebral malignancies, chemotherapy drug, antipsychotic, antidepressant, tricyclic antidepressant, recreational drugs, my friend. I already said that. If you're writing a question, of course, it's going to be about ecstasy, MDMA can cause SIADH, okay? Then you look at the ectopic production of the ADH. We're talking about small cell cancer, esophageal cancer, duodenum, pancreas, and all those 9 causes. And then finally, you got the potentiation of ADH by chlorpromide, torbutamide, carbamazepine. Carbamazepine role is very, very important, okay? Now we just kind of look at the normal physiology. What happened? Osmolar receptors in the hypothalamus. They watch the osmolarity, like your V2 receptor activation in the principal cells of the collecting duct, and then you got G-coupled receptor, right? And then GS protein is involved in here, and then activation, right? Everybody got that? Adenyl cyclase, protein kinase A, aquaporin channel, boom. Water get reabsorbed from the collecting duct, right? So when the water get collected, it go to the blood, right? So what happened? When you have increased ADH, too much, volume increases, so your plasma osmolarity goes down, right? So, urine is lost, urine become concentrated, increase urine osmolarity. That everybody know, like the most common finding, right? And then also you have to think about the urine sodium loss is going to be like, if you look at the urine sodium, it'll be greater than 20. How does it happen? First, you have the decreased serum osmolarity, right, which you already know. And then what happens is like transient volume expansion that cause increase the ANP, increase BNP, and decrease aldosterone. That kind of cause sodium loss in the urine. That's why sodium is less than 20. The most important thing, how does the body keep it? This is a euvolemic hyponatremia, right? Euvolemia. That's what the most important thing. How does it keep? First, decrease serum osmolarity, transient volume expansion. There's increase ANP, increase BNP, decrease aldosterone, right? And then what happens is like water follows. When you have sodium is losing, water follows it. So body keep that homeostatic balance. So euvolemic hyponatremia. And then the most important thing is also the diagnostic criteria. You look at the hyponatremia less than 130. You look at the serum osmolarity less than 275. You look at the urine osmolarity greater than 100. Urine sodium greater than 20. And then you got eulemia, you look for the clinical signs and make sure the patient is not on diuretic, patient does not have, thyroid or adrenal problem. And the treatment is pretty much, if I have to like think about the asymptomatic treatment, which is the most of the patients usually asymptomatic, fluid restriction is the treatment, and then make sure you know the formula so you can tell the patient how much fluid we have to restrict, okay? And the moderate symptoms, you give IV fluid with the LASIK, and severe patients, severe symptoms, you have you can give like hypertonic saline to correct it. Okay, so very it's an important examination topic. Everybody need to know about this SIADH. If you have any questions, please put it under comments. Thank you for joining us. Please subscribe to our channel because it takes a lot of effort for a lot of people to make presentations like this. Again, thank you from the bottom of my heart. Thank you.